Hi, I'm Dr. Joe Rogers, President and CEO of the Texas Heart Institute, and we're in the studio this afternoon with Dr. Hernandez from Baylor Scott White, who has just given grand rounds at the Texas Heart Institute, giving us a current update on cardiogenic shock. Dr. Hernandez and his team have been instrumental in helping us develop a body of science and scholarship around the field of cardiogenic shock, and have really pointed out some of the challenges that we've had up to now in studying cardiogenic shock patients. So we're very happy to have you here in the studio just to have a follow-up conversation on your great grand rounds today. Thanks for joining us.
Thanks for having me. It's been an honor.
Many of the topics that we touch on in this particular series are sort of how you take the science that you presented today and apply it practically. And you covered an incredible body of information, but I want to boil this down to what you do practically when presented with a patient who shows up in the emergency room with what you believe is cardiogenic shock. What do you and your team do? What is your approach to managing that patient clinically from that point until you make some definitive decisions?
Yeah, so we try to profile patients. We try to identify from a clinical, hemodynamic, and imaging standpoint what is the cause of cardiac shock, whether this is related to heart failure, ischemic disease, or some sort of torrential inflammatory condition. We want to identify also what level of severity they have, and then we have to decide whether we have to bring other team members into the mix in order to identify whether they need or not certain interventions like critical care related interventions, like temporary mechanical circulatory support, in order to stabilize the problem, normalize their end organs with a focus on their lungs, liver, and kidney, and open an opportunity to then decide what is the next best step for these patients.
You emphasized today the importance of hemodynamic profiling, which I think is also very important. But how do you use the PA catheter in your diagnostic algorithm? Are you using it frequently or infrequently? We talked a little bit about the fact that it's hard to use a PA catheter based on the data, but I actually think in this particular patient population, which is not well studied, it may be very advantageous.
Yeah, so we try to bring these patients to a cath lab if there's access, or in the critical care unit, which most likely they're going to be transitioned upon. We try to do it as early as possible. And having that information will give us an idea whether the current medical interventions, whether it's diuretics, inotropes, are helping this patient, or do we need to escalate to more robust interventions like temporary mechanical circulatory support. I think the challenges are not only in putting the catheter, but actually interpreting the information. We have an opportunity here to make sure that patients have full profile, understanding their right side, their left side, and the interaction with their lungs. So having an emphasis on not only doing it quickly, but doing it right, and following these patients longitudinally with the right data is one of the challenges, but also the opportunities that emerging programs that are dealing with this disease in a more connected and interdisciplinary way have for the next several years, and through registries, through trials. I think we have a good opportunity to best understand what is the impact of that early invasive hemodynamic profiling.
Now, you've also developed the concept of hemometabolic shock. And so that would imply to most of us that you're measuring some parameters that tell you something about the metabolic profile of the patient. So can you elaborate on that a little bit? What are the specific tests that you're doing to sort of classify that patient population?
So we think that perfusion is impairing cardiac shock, and there are certain markers of perfusion, like for example lactate, but also some end organ dysfunction parameters like renal injury, liver injury, and persistent pulmonary congestion that coupled all together lead us to this concept of going beyond the heart injury, but to a more system-wide problem. And I think acknowledging the impact that injury has chronically on these patients that present in a decompensated state or de novo, will allow us to understand and evaluate the responsiveness of particular therapeutics, whether it's medical therapy or device-related therapy. But sometimes that requires some degree of further knowledge of where did these patients started to have their original problem, whether it was something new that developed with heart failure or something chronic that they have been dealing with for years and now just open up to a situation that they were needing to have critical care interventions.
Now, one of the other things that you and your team have done is distinguished for us the importance of thinking of, not about cardiogenic shock not as one disease process, but actually being driven by different disease processes. And in your talk and in many of the things you've written, you've distinguished between AMI shock and heart failure shock. And I wonder if you have some thoughts about, you talked a little bit about the prognosis of those different groups, but how do you think that distinction has driven some of our therapeutic trials? You know, and it strikes me that so many of the AMI shock trials using a device intervention have been negative. Have we been studying the wrong patient population? And if you studied sort of the chronic or acute on chronic decompensated heart failure population with that same intervention, would you get a different result?
Yeah, I think what we're finding is that the timing of intervention for perhaps both phenotypes at a large scale, IMI cardiogenic shock and heart failure cardiogenic shock, is perhaps advanced. And perhaps advanced in the sense that these patients already perhaps have not only profound myocardial or hemodynamic implications of their disease, but also metabolic, and also sometimes leading to cardiac arrest, which really changes their trajectory. I think the devices are being platformed in trials in a population that is still need to be further profiled, and there's a interest approach for future trial designs to try to really classify these patients, not only from a clinical standpoint, but also from a hemodynamic and imaging standpoint. So I think as we better understand the disease trajectories of both IMI and heart failure shock from a tailored disease classification scheme that involves hypoperfusion, treatment intensity, and where did these patients started their journey? Did they start at E with a cardiac arrest, or they started with a B in the office? I think we'll find at least that middle point in which perhaps trials can change from ongoing negatives to some signal of positive that can change the practice across the world.
So I want to just ask you about one other patient population that I think is fascinating and understudied. And you touched on it just a second ago by this group of patients who have ambulatory cardiogenic shock who come in the office. And you and I take care of a lot of these patients in our careers because we're following people who we're thinking about for transplant or mechanical circulatory support, and they might have an elective right heart cath and we find they're in shock. What do we actually know about that ambulatory cardiogenic shock population, and how should we be managing them?
Yeah, I think we know little, but I think the future is bright. And I say this because this population is increasingly being scrutinized from an invasive hemodynamic standpoint. We now have ambulatory devices that can measure hemodynamics longitudinally, and I think the definition of where is the problem here, if it's refractory congestion leading to end organ dysfunction, then leading to worsening myocardial injury, or whether it's just myocardial injury in itself leading to end organ dysfunction, those trajectories are not very well identified. But we have now a lot of data to analyze from the index time in which we see low output heart failure, then longitudinally in the office with these ambulatory devices. I think that there is a need for registries with advanced heart failure population that we see in the office to actually identify that transition to time zero when cardiac shock starts. And I think that window of opportunity that we all see as a major or the most important challenge for advanced heart failure programs of identifying that I think you and I that have seen many patients, it's perhaps a little bit easier than the internist or the cardiologist, but it's still not very well defined. It's almost an art still. So as we have and gather more insight through index admissions, invasive hemodynamics, longitudinal trajectories, we'll be able to perhaps crack that code of uncertainty where this patient really needs to have close attention for heart replacement or advanced therapies, or where this patient is safe in the ambulatory setting.
Well, I'll just say again, I'm so appreciative to you and your team and the Cardiogenic Shock working group for putting so much energy and passion into this space. I think you're answering important questions that have gone unanswered for decades, but characterizing the population, helping us understand different ways to phenotype them has been so important. And thanks again for visiting us at the Texas Heart Institute today.
Thank you.